Good morning and welcome. I'm here with Kayrish from the National Council on Aging, and we're doing our annual Medicare for NET, something that we've tried to do every year when we can, and learn about our Medicare options for neuroendocrine tumor patients, and really learn how to do a Medicare checkup. And it's such a pleasure to have you here again. I know things have changed a little bit and from previous years, and this year we're actually doing it a little earlier than normal, which is great. And it's such a pleasure to have you. I'm going to turn the screen over to you, but just a reminder to the folks who are watching, we're broadcasting live now on YouTube, on our Facebook page, on Twitter, on just on enough social media. If you want to ask questions, you can ask them wherever you're watching. You will expose your information publicly, and if you would prefer to actually not do that, you're more than welcome to actually go to our Slido page, which is let me actually get the Slido for you, so that you can actually just go and ask them anonymously. It's a little bit of a mouthful here. I'll try to get the short link for you as well, but yeah, that's a little bit of a mouthful. I'll get the short link for you, and you can ask things anonymously as well. But in the meantime, Anne, it's a pleasure to have you here, and welcome.
Well, thank you. Thanks, Josh. It's great to be here with the NETS community again this year. As you indicated, there are a few things that have changed, and we'll go through that and making sure people know how to make a change in plans if that's something that they do indeed want to do this year.
Well, we'll let you start right away. Let me get you back into with your slides here.
I can't do it completely from memory, but we'll try. There we go. Okay, why don't you go ahead and advance the slide. So I know when we normally come here, we kind of like to set the ground, the stage, and go through some of the Medicare basics, and we'll go through Medicare A, B, C, and D. We'll talk about the enrollment, which there have been some changes in that enrollment, which we'll cover, and specifically talk about this time of year, which is our annual enrollment period, which runs from October 15th until December 7th. And then we'll actually go on to and talk about Plan Finder and what you need to do to compare plans for 2023. And then we'll go through a number of the 2023 Medicare changes. If you want to go ahead and advance the slide, Josh, thank you. Like I had mentioned, we certainly like to do a level set as to what is Medicare. And for the audience, Medicare, as you probably know, is a federal program that does indeed provide health insurance. And it normally, at beginning anyway, it's for people who age in at the age of 65. So if you're age 65, Medicare is certainly an option for you. If you are under 65 and you are receiving a Social Security disability income, then you could also enroll into Medicare. And now individuals who have ALS or end-stage renal disease are also eligible to enroll into Medicare. And there are certain parameters on that, but we can talk about that if people indeed have questions. So that gives you a lay of the land of who is eligible for Medicare and what it is. If you want to go ahead and hit the next slide there. What people also ask when they think about starting Medicare is, who am I going to get contacted, or do I have to contact? Who do I contact? It's a big question. So it's important to know that if you are receiving Social Security benefits when you turn 65, then the Social Security Administration will send you like a Medicare welcome packet, which has your Medicare card and instructions on how, if there's any type of enrollment you need to do. What's kind of confusing for people is that you're enrolling into Medicare, but you have to get in touch with Social Security, and Social Security is the one that triggers that enrollment. That is indeed the case. So if you are receiving Social Security benefits, then Social Security will send you this packet. If you are not receiving Social Security benefits, you're not collecting those benefits, then if you want to enroll in Medicare when you turn 65, then you're going to have to contact Medicare in order to, or contact Social Security in order to do that. And you can contact Social Security. You can certainly call the number, or you can certainly go online and go onto Social Security and look to enroll into Medicare that way, or you can go ahead and make an appointment if you can. The important piece, which I like to talk about a lot here, is what if I'm turning 65, but I'm continuing to work? If you're continuing to work and you have insurance through your employer-based insurance through current employment, then you do not have to enroll into Medicare when you turn 65. You can delay that enrollment, and there will be no penalty or problem enrolling later on. You'll get a special enrollment period. What I do want to reiterate at this point, though, is it has to be current employer-based insurance through yourself or through your spouse. You could not count, COBRA coverage does not count, or retiree coverage does not count. If you have COBRA or you are using retirement coverage and you are turning 65, you want to enroll in Medicare at that time to avoid any penalties or late enrollments issues. Let's go ahead to the next slide, if you will. When you're enrolling into Medicare, you really have a decision to make. Are you going to go with original Medicare, or you're going to go into a Medicare Advantage plan? Right now, it's really that half of the people who enroll in Medicare are enrolled in original Medicare, and the other half are enrolled in Medicare Advantage. So what does that mean? Original Medicare means that you are going to take Medicare and you're going to, it's basically like you have to buy a bundle of services. You're going to be able to see doctors that don't have an affiliation with the plan. Your plan will, you can see any doctor, but you will get Medicare Part A, okay, which is what covers your hospital coverage. And then you'll have Medicare Part B, which you'll need to pay a premium for. You will also need to enroll in a Medicare Part D plan, which also has a premium. And you will also need to purchase a Medicare supplement plan. So you can see there are multiple pieces of this. So if you're going to go with original Medicare and want full coverage, you'll need your Medicare Part A, which you can enroll in, and it costs nothing as long as you've worked more than 10 years. You'll have to pay your Medicare premium for Part B. You'll have to enroll into a Medicare Part D plan, which does have a premium, and you'll have to buy a Medigap or a supplemental plan, which will also have a premium. So you can see you have different checks or something there you're going to be writing each month. The Medicare Advantage plan, what it does is combine your Medicare Part A and B. You still have the same coverage, and again, you don't pay a separate payment for Part A if you've enrolled and had worked for 10 quarters. You will have to continue paying your Medicare Part B premium. You will have to then enroll into a Medicare Advantage plan. And like I said, Medicare Advantage combines your A and B coverage. So you're getting it through a private insurance company. If you may hear about it, maybe something like an Aetna plan, or maybe you know that there are plans with our like Humana. Those are Medicare Advantage plans. And more often than not, they cover and include a Part D benefit. So you're not shopping for the most part separately for a Part D plan, and you do not have to buy a Medigap plan, as a matter of fact. And some of the Medicare Advantage plans have extra benefits, which you may be hearing about. And some of them, they can have dental, or maybe they'll have some kind of food delivery service. So when you're first enroll in Medicare, these are the choices that you need to make. When am I going to go with original Medicare, or am I going to go with Medicare Advantage? Okay, so let's move on, unless there's a question that has come up, Josh, that you want to have me answer.
No, I thought one of the big interesting things, of course, we see more and more ads for Medicare Advantage, and we'll talk about that in a little bit. Yesterday, I believe I sent you, I know I sent you an article that was done by the New York Times on the difference between or some of the understandings between Medicare and Medicare Advantage. And I found that it was especially interesting when they talked about that, 50% less, or I can't remember the exact number, but of those on Advantage went to specialty surgical centers for their cancer treatment. And while you have the Part A and Part B is the same on both of them, there was also part of this article discussed the number of times, or I think it was about 10 to 13% of the times that things that original Medicare allowed that Medicare Advantage plans did not allow, and that most of them were overturned on appeal, like 75%, but only 1% of the ones who were denied actually went back and did that, and went and filed that appeal. So I think while there's a lot of check marks on the original Medicare side to go through, and certainly Advantage seems easy, and I know you'll talk about this as well, but understanding the challenges of, especially for people who have rare diseases and may see many specialists, what the challenges of that are. And I know we might get into it, but I just thought I'd bring up that New York Times. Any thought on that article?
Absolutely. Well, I know, go to the next slide and it'll definitely feed right into what we want to talk about, right? So we have to remember with Medicare Advantage, there's going to be gatekeepers of care. Okay. So the Medicare Advantage, as you can see here, you're going to have to use network providers. So that's the first issue, that you have to make sure that the primary care physician, which would likely be in the network, because they may, if you know someone, or they may assign you a primary care physician, but for this particular community, you're going to use specialists. You would want to make sure that the specialists that you are seeing are within that provider community that is offered by that Medicare Advantage plan. So that becomes something really important. You want to make sure that that specialist is certainly participating in the plan. Okay. You'd also want to make sure that recognizing that with the Medicare Advantage plans, you indeed have prior authorization requirements that they use it as utilization review type of things. So that's something that normally original Medicare doesn't have. So you can see if you have really tight requirements in terms of the type of specialist you need to use, you can see how that could be a downside of your Medicare Advantage plan. And in the article that Josh had mentioned, and a few other articles, what they were talking about was that people often, there's an initial denial of a prior authorization. And then if an individual would actually have gone to appeal that denial, they probably would have gotten it covered. But often you don't know that. And again, that happens under that Medicare Advantage plan, that they have found that these prior authorizations, in some cases, there's a lot on the front end and people don't choose to appeal, or don't even know that it's a good idea to appeal. So you could see how that gatekeeper system continues to work. And again, it does work for people. And in some cases, if their providers are there and they're willing, they may get the benefit of some lower co-pays or things like that. And typically the premium on a Medicare Advantage plan, and that's often a selling point on a Medicare Advantage plan, is that the premium is lower. And again, these supplemental benefits, which can be helpful to people or two, that could be a draw. I want to mention that. And they often have prescription drug coverage, and it's often pretty good prescription drug coverage. The other piece I want to mention with your Medicare Advantage plan, as long as we're going down the list of the Medicare Advantage plans, is that it could be that if you enroll into a Medicare Advantage plan and then, you may have difficulty later on being eligible for a Medigap plan. Let me talk about, so that's what my thought on the Medicare Advantage. Let's talk about some of the pros and cons in terms of the original Medicare. Know that any provider who accepts Medicare, they can be a provider for you. So that's a good piece of news. And you'd have to purchase a Medigap to cover those Part A and B costs. And normally if you have a Medigap and a Medicare, original Medicare, you pretty much have full coverage. So that's 100% coverage. And you will have to purchase a Part D plan for prescriptions. And the other piece of it is that you're not going to be having access to any type of additional dental rider or any type of home delivered meals or transportation. That's not available currently under original Medicare. So those are the things you're weighing as you are picking Medicare Advantage over original Medicare over Medicare Advantage. So keep that in mind as you're going through this choice process.
Can you talk a little bit more about, since, you know, all the viewers of this particular version have some form of cancer, some form of neuroendocrine tumor cancer. So the last bullet on the Medicare Advantage, and some of them, you know, are taking this in as prior to age 65, which I think we'll get to at some point here. But the limitations of to later leave, what that means as far as what the Medigap policies can actually rate you on, because as far as I remember, the only thing they can rate you on is age, which is oddly one of the weirder things, that as you get older, it potentially gets cheaper for those who are under 65 who have a large Medigap payment and get to 65 and it goes down oddly, but can you discuss that a little bit?
Sure. Well, remember, the Medigap market or Medicare supplement market is different. It is regulated by the states. Okay, so each state can have parameters as to whether or not if there's a guarantee issue period for people after their original Medigap guarantee issue period. Let's start there. When you're turning 65 and you're enrolling into Medicare for the first time across the state, it's a federal requirement that you are able to purchase a Medigap plan at that point in time, and every Medigap plan has to accept you and give you the best price. That is like one of the few guarantee issue rights across the board. If you enroll in a Medicare Advantage plan when you're first eligible for Medicare, but then you want to leave within a year, leave that Medicare Advantage plan, you have a guaranteed issue right in every state to a Medigap plan. So if you enroll in if you enroll in a Medicare Advantage plan for the first time when you got Medicare, when you turn 65 or first eligible, as long as you withdraw out of that Medicare Advantage plan, and again, within a year, you can pick up a Medigap plan. So there are limitations. Beyond that, there are not that many federal guarantee issue rights. Now, different states have made other arrangements. In some states, there's a guarantee issue right when if I'm 65, if I'm under 65, I can get a Medigap or Medigap plan. Sorry about that. If I'm under 65 in some states, I can get a Medigap plan regardless, but that's not available in every state. There's not a guarantee issue right across all states for you to be under 65 and get a Medigap plan. That's not the case. And I know California has it's different. In California, I believe if you're enrolled in a Medigap plan at some point, you can enroll into a different Medigap plan. But that is one of the requirements, but I don't think it's beyond that, if I'm correct. So getting a Medigap after you've had a Medicare Advantage plan, after that initial time, can be very difficult. You can be denied coverage by the Medigap plan, or they can raise your rates in order to cover you. So you're not guaranteed coverage under a Medigap plan after those initial times. So it's tough.
And I know we'll talk about resources like SHIP counselors, but this is one of those areas where talking about your individual situation and trying to figure that out state by state, because this is going out to people across the country. It will be different state by state. I think there are 4 states that allow you to actually do the Medigap plan guaranteed issue, regardless of if you went to Advantage first, but that's a really small population, and it certainly isn't in California. Makes me think about moving to Connecticut, because I know my father-in-law has a house there, and they're one of the places, so I have an address already.
Right. Exactly.
All right. Moving on.
Mm-hmm. I think it's always good just to know that never think about this as a one-time thing. You have to look, especially if you've got you've got a disease or a chronic situation you're dealing with, you really have to look long-term. You have to kind of keep in mind that the cheaper premium may not necessarily be the best way to go all the time. So this is just a reminder. It's a reminder to you, enroll into Medicare when you're first eligible, okay? And I'm reiterating that if you have insurance through current work, then you can delay enrollment into Medicare, okay? Particularly Medicare Part B. But again, your COBRA is not going to be eligible, okay? That's not considered current work. All right, you must have continuous coverage since becoming eligible for Medicare, including the month that you became eligible for Medicare, meaning that if you just said, I opted not to enroll into Medicare when I turned 65, you better continue to have that employer coverage until you then want to enroll in Medicare later on down the lines. Do not have any gaps in that coverage, okay? If you are currently on a marketplace plan when you're turning 65, you will want to enroll into Medicare, and they'll tell you want to enroll into Medicare because Medicare, the marketplace plans, that the subsidies are going to cease if you are getting any of those subsidies. And it is designed for people up until they turn 65. So the marketplace is not going to be for you once you're Medicare eligible. All right. And if you choose not to enroll in Medicare, you are going to be subject to late enrollment penalties. And how it works is there'll be late enrollment penalties for Medicare Part B, which is equal to 10% of the Medicare Part B premium for every 12 months that you have should have been enrolled into Medicare and were not. So for that, after 12 months, you have a 10% penalty. If you go another year, you're at 2 years, that's a 20% penalty. You're also going to have a penalty for Medicare Part D as well. That's for your drugs. So you'll have a drug penalty as well. So you'll certainly want to enroll into Medicare when you first need to and eligible. Okay. So I'm sorry, this is kind of hard to read here, this Medicare enrollment periods. So as you know, again, your initial, and let's talk about all these enrollment periods. There are opportunities to enroll in Medicare, okay? The first three, which are in the green, we've seen some changes this year. So I would ask you to pay attention to this because there's some changes this year. For your initial enrollment period, for Medicare, let's say you're turning 65 or you're under 65 and you're coming around to that 24th month of your disability. And when you're in the 24th month of your disability, then you would be Medicare eligible. So how this works is your initial enrollment period is 7 months long. It's easier to understand if it's the 3 months before your 65th birthday, the month of your 65th birthday, and 3 months after your 65th birthday. That is your initial enrollment period. So there's been some changes to that, and we'll get to that a little bit more. But let's go through all of these. We'll come back to that. So the general enrollment period is if you miss your initial enrollment period, you're going to enroll in general enrollment period. It happens every year. It's annual. It goes from January 1 to March 31st each year. And people enroll in their general enrollment period when they've missed their initial enrollment period. We'll talk about that, but I want to stay right where we are right now. There's also special enrollment periods, and these are special exception type of circumstances. And maybe you get that technically when you lose your employer coverage, that's considered a special enrollment period. You have an opportunity to enroll, and we'll talk more about that. But the last three, there's been no changes to them, and we'll just count them off here. You have your open enrollment period, which is what we're going through now, which is October 15th to December 7th. And that's when you can change your Medicare Advantage plan, or you can change your Medicare prescription drug plan. Continuing with the changes with Medicare Advantage plan, we have a second period, which goes from January 1 through March 31st. Say you picked a Medicare Advantage plan during your open enrollment period, and it was effective January 1. On January 1, you determine that this plan, or January 15th, you determine this plan isn't working for me. You can then enroll in another Medicare Advantage plan. You can enroll into another Medicare Advantage plan, okay? Or you can disenroll from the Medicare Advantage plan, and you can go back to original Medicare and then pick up a Part D plan. Okay, so you can disenroll from your Medicare Advantage plan. But this is when it becomes difficult to pick up that Medicare supplement. So that's a drawback. And the last one is this Medigap open enrollment period. And that is when you cannot be denied coverage for a Medigap. And that happens from the 6 months beginning the month you turn 65, then you turn 65. So that is your guaranteed period. It's a 6-month period. You cannot be denied. So let's talk a little bit further about the ones that are in the green. And they're the ones that we've seen changes for 2023. So if we go ahead to the next slide, please. So what we're finding, or what's going to happen beginning in January of 2023, anyone who enrolls into Medicare during that general enrollment period, that January 1 through March 31st, previously, you had to wait until July 1st for that Medicare coverage to kick in. That is changing as of January 1. Now, if you enroll in January 1, your coverage is going to be the next month. It's going to be February 1st. If you enroll in March, or if you enroll in February, you'll enroll in March. So you can see it's just the month after the month of enrollment. So it reduces that waiting period if you are enrolling during that general enrollment period. Okay, so that's important. The next changes that we're going to talk about is for the initial enrollment period. Okay, you've turned 65 and you are enrolling in Medicare. And the changes for the initial enrollment period is, again, remember, you can't get Medicare until you turn 65, that month of your birthday. So there's no changes to that. If you're enrolling up until you turn 65, the month of your birthday, your eligibility is going to be the first month that you're eligible at 65. Okay. If you enroll during the month of turning 65, then the first day of the month following the month of enrollment happens. But that is how it's always been. The changes to the IEP is the month after your birthday. If you waited, say your birthday was in August, and you waited until September to enroll, there was a delay. It wasn't the next month. It was 2 months later. Now, instead of having that delay to that second month, you can again enroll. You'll get enrolled the month after you enroll. So if your birthday was August, you were enrolled in September, October 1, you would be enrolled in Medicare. That is they decrease the waiting time. Similarly, if your birthday was in August and you waited until September, October, your Medicare effective date is going to be November. It would have been 2 months later, or 3 months later, actually. So you can see they've cut these enrollment at wait times, the coverage times. So that's very helpful. Let's move on to our next enrollment period we want to talk a little bit more about. So they've added some special enrollment periods for Medicare Part A and B. Right now, what they're saying is if you were not able to enroll into Medicare Part A or B due to an emergency or some kind of disaster, I think about what's just happened in Florida with Hurricane Ian. If there was some reason you couldn't enroll, you missed your Medicare Part A and B enrollment period, because of that, you didn't have any power, or the person that you rely on to help you was impacted, then you have an opportunity to enroll into Medicare after. It gives you another chance to enroll into Medicare. Similarly, if your employer, there was some kind of error on their part and you missed your initial enrollment period because of some information you received from your employer saying, hey, you don't need to enroll, you'll be fine, then that gives you another enrollment period. People who are coming out of prison or formerly incarcerated, they also have an opportunity to enroll into Medicare after they're released from prison. Also, there's a coordination with the termination of Medicaid. Not every state made that an enrollment opportunity. So now in every state, if you are coming off of Medicaid, you can now enroll into Medicare. And there are other special exceptions that CMS has determined, like we recognize things happen and these are opportunities. So that just gives you an idea that there's more options, but you don't see anything in there about you don't see the Medicare Advantage plan changing a provider network. And that is a reason I want to come out of my Medicare Advantage plan. You don't see anything like that. These are only for these specific situations. So let's move on to our next enrollment period, which is our open enrollment period for Medicare Part C and Part D. That is what's happening right now. Again, it happens on October 15th. It begins. And this is your opportunity to change your Medicare Advantage plan or to change your Part D plan. And that's your drug plan. So prior to Medicare open enrollment, normally around the 1st of October, you should have received an annual notice of change, which is a mailing from your plan telling you about all the changes that are going to happen. It's going to list if we're covering a drug differently, if we're not covering a drug. If you're in a Medicare Advantage plan, it could tell you there may be a different copay schedule. All of this comes to you and you're supposed to read it so that October 15th rolls around. You're going to say, this plan might be the one for me this year, because maybe you don't know, plans change every year. What they cover changes every year. How they cover it changes every year. Maybe they have different formularies have changed. Maybe they have different exclusions. You need to look at your plan every single year, and this is your opportunity to make a change. You can change anywhere from October 15th to December 7th, and that change will be effective as of January 1. So that is the open enrollment period that we are in right now. And again, as we mentioned before, if you're in a Medicare Advantage plan and you're going to change your Medicare Advantage plan, and as of January 1, you pick a new one and you find that doesn't work, there is another opportunity to switch out of that Medicare Advantage plan as well. So let's go on to the next slide, if we may. So that covers all of our enrollment periods, okay? Now we're going to move a little bit more into what Medicare covers. And I don't know, before we move on, Josh, do you want to take any questions about timing of enrollments or anything like that? Or would you prefer to do that all at the end?
I don't think we have that many questions on timing. There was one question about, someone's husband was going on to Medicare and they were covered under their private insurance. The person was covered under the private insurance, but is under 65. So, what are their options until they get to Medicare age? Can they? If your spouse is the person you get coverage, they're getting Medicare because they're retiring and turning 65. You're left with potentially going on COBRA or an ACA plan until you get to 65. What's your thoughts through that?
Yeah, that's exactly right. It's really important to be aware that because the one individual, Medicare, there is no family plan with Medicare. So it's purely an individual. So what you want to know is that, if someone's turning 65 and they were managing you and they were taking care of your insurance coverage, you're not going to have that moving forward. So again, you could take COBRA or you can join an ACA plan. I would say that you're probably going to have to weigh the cost of being responsible to pay the full amount of that employer coverage. And you'll want to, or compare it to a Medicare or to an ACA plan. Yeah, that's exactly right. That's exactly what you'll need to do. Yeah, that's what they have. The navigators may be able to help. Those ACA navigators may be able to be helpful.
All right, I think that was the only question about open enrollment. There's more questions as we go through more of coverage things as we get through, but you're going to show that with some examples you have later. So we'll continue on.
Okay, fantastic. So now we're turning to what does Medicare cover? And the important thing to keep in mind is Medicare covers things based on medical necessity. That is the parameter that they're going to use. Is something medically necessary. They're also going to make sure that it is not experimental or investigational. And I think this is where it comes up against some of the situations you all may find yourself in, because it's important to know whether the treatment you're having is covered for your diagnosis. Is it FDA approved for your diagnosis? I know there are a lot of things that are used off-label, and that may not be covered under Medicare because it's an off-label use of a particular treatment. So keep that in mind. The other piece you want to keep in mind is that If you want to know in advance whether something is covered, you can ask your provider if they would get a Medicare advance. Like, could you get a decision made up front? Can you like, provider, can you check and see if Medicare will cover before we go ahead with this? Because maybe the provider is uncertain. And if something is not going to be covered, your provider should give you a Medicare advance beneficiary notice of non-coverage. But let's talk about this before we go crazy on it. Let's use this example first. There's not going to be a requirement for an advance beneficiary notice of non-coverage for something like, I don't know, plastic surgery or something like that. Medicare generally doesn't cover plastic surgery. So that is not something that you're going to get, your provider is going to need to give you an advance beneficiary notice on, okay? What would be more likely would be saying that you need, see, there's a screening. I'm just going to say a colonoscopy screening or something like that. And maybe you would like your screenings more frequently than Medicare covers. Maybe Medicare covers it once every 24 months. But you would like one done every 12 months. Well, in a situation like that, your provider should say, well, and maybe you need to know that this may not be covered, and I need to let you know that. So if you're going to want to do this, you need to be aware of that. So that's what happens with these advanced beneficiary notice and that types of things. There's a good chance it's not going to be covered, your doctor should let you know, because then you have to be responsible for the cost of that. So I wanted to make sure I brought that up. So if you find yourself in a situation where you don't know if something's going to be covered, and you have that conversation with your provider and say, could we send it up to Medicare or send it and see if they'll cover it? And that way you'll know. And that's something you probably want to do as well. And I think it's interesting when we had talked about the prior authorizations, that the Medicare Advantage plans can indeed use a prior authorization. But again, if you can determine and your provider says something is medically necessary, you certainly can argue for the need for a procedure. And this is how those prior authorization requirements are overturned. So that's what you would need to overturn anything like that, is to get letters from your doctor and supporting the need for the medical necessity of something. And that's how I would always approach it. If you're ever finding that there's something that may not be covered, you want to make sure your doctor is establishing a case why you need to have this procedure done. Okay, so let's move on to the next slide. Okay, let's talk more about some covered services. As we talked about, Medicare does cover most phases of your end-stage renal disease. If you are on dialysis, Medicare will be covered. It's like ALS in that you get Medicare coverage early by the diagnosis itself. Important to this community is their coverage for Medicare does cover, a variety of therapies, including the PRRT therapies and the Lutathera-based, I think it's a therapy as well. And it's based on medical necessity for FDA-approved diagnoses. Again, this is back to what is approved through the FDA, and Medicare covers those therapies. And from my understanding, most of these therapies are done in the hospital, right? Am I right? Or in conjunction with the hospital?
Yeah, or
right?
As an outpatient. So
right,
actually, Lutathera is a brand name for a version of PRT. So
okay,
thanks. They're one and the same there.
Oh, well, thank you. Thanks for clarifying that. But I know these are done normally like outpatient procedures, and this is going to be a Medicare Part B types of coverage. So we'll get into that as well. So because it's not something you can do at home at all. So we'll talk about that. Yeah. Medicare also covers a variety of tests like your CT scans, your MRIs, your EKGs. And again, these are all the situations where you're going to have your provider documenting that these things are medically necessary. And I know these can be very expensive. And I know these are sometimes a point of contention because maybe your doctor wants a more frequent scan and maybe it's not covered by Medicare. And these are the situations where you probably need to be collaborating with your doctor to make sure you're getting as much coverage as possible. All right.
There was a question that just came in that we'll address right now. Does Medicare limit how often scans such as MRIs, PET CTs are done as long as your provider says they're medically necessary?
My understanding is the way that your doctor is really the driver in a lot of this, that they are seeing if it's reasonable and they're going to say, I need to prove this. And the doctor will provide verbiage for that. And I think that that's generally the case working with your provider. Again, I think you're going to have to think about what's medically reasonable, and there will probably be discussions with this. And I probably all have experiences with this, but you really need the doctor's support to document how frequently you need the scans. We often all rely on our doctors to make sure that we're getting the care that we need. So it's normally, it may be, they may ask questions why it's so frequently, why you're doing something as frequently or not. What I also know is, like, here's what I often find is, like, if you're getting a treatment at one facility and then somehow you move to another facility and then they want to do a whole other series of scans or things, sometimes that could be an issue, being that you just had the scan, but that new provider would like their own. They trust only their own facilities work. So I know I just, in my own husband's situation, that's some of the issues that we sometimes have, is that new providers don't trust some of the old providers' work, and they want to get their own scans. We've had a lot of that covered, but I'm just saying sometimes that's an issue.
Medicare has, certainly for PET-CTs, has done something called appropriate use criteria, and they would like to see by a medical body or a group of bodies appropriate use criteria for the use of certain imaging, and they will, they'll, rather than a time-based way of looking at it, they want to know whether it meets an appropriate use for it. And so many scenarios, I'm a co-author of one of the appropriate use criteria for DOTA PET-CTs, where I believe we're up to 9 indications where they're appropriate, and 2 that are borderline, and some that are not listed as appropriate. And inside that general area of, if it's in the appropriate use criteria, they'll cover without much question, because that has been set up as a standard that they accept. The other challenge, of course, is, and this is true for NETs especially, is getting, as you said, scans close together. When you're trying to do a PET-CT can be done with something called a sugar PET or FTG, which is appropriate for some forms of more less well-differentiated neuroendocrine tumors, but most of us get something called a DOTA PET, and some of us need to get both of them, and having them both together too soon leads to coverage issues that your center will work out and talk to you about and see what the timing is to get that covered. So that is a challenge as well. And that is one of the challenging areas of imaging as well. Most of them will, going to bullet 2, have a pretty good track record now of understanding what the FDA will approve, and if any pre-approval is needed for things like LU-177 dotatate. And they'll work with it beforehand. They'll let you know if they don't think you're they're going to get paid for it. I always shy away from saying I'm accepting any cost on anything you don't get pre-approved. So moving on.
1 second, I want to ask a question, if I may,
Sure.
Josh. When you talk about the appropriate use, do you know is that a national type of appropriate use?
Yeah, it's a appropriate use criteria that's accepted by the FDA. It's in imaging for NETs. It was co-done by NANETS and the Society of Nuclear Medicine and Molecular Imaging. There's probably the surgical group as well, SIO, and one more that's in there as well. And it meets certain criteria, and these things get updated periodically as well. And there's ones on prostate cancer for PSMA imaging as well, and a few other indications. And these are specifically for PET-CTs.
Fantastic. That's great news. Okay, thank you. Thanks for clarifying. I learned something today, so thanks so much. Well, let's talk a little bit about prescription drugs. Okay, whether you're in a Medicare Advantage plan or whether you have buy a standalone prescription drug plan, you are going to, have access to a Part D, which is your prescription drug covered through Medicare. Okay. What it is there are different private plans that actually administer this benefit for Medicare. And as I said, it's available as a standalone or with part of a Medicare Advantage plan. So the Part D benefit is, it's not designed to be the simplest benefit, okay? Normally when you have a Part D plan, you're typically going to have costs when you go pick your drugs up at the pharmacy. And depending on where you are in the phase of the prescription drug benefit, it's going to really impact your cost, okay? So let's look at some of the different phases of the Part D benefit. You first are going to have your initial deductible phase if your plan has a deductible. It could be a $50 deductible, $100 deductible, or more. It could be that you are going to be responsible for all the costs in that phase until you meet that deductible. You as the individual is going to be paying for that cost, okay? The second part is your initial coverage phase, and that is where you and your insurance company are paying a percentage. You're paying, generally it's 25%, and the plan is paying a 75%. We've seen some shift in the initial coverage phase because right now what you find that there are any number of drugs and any number of plans which actually offer co-pays in the initial coverage phase, which are generally less than that 25%. So this is something that is not across the board, that it's always 25%. Typically, it's no more than 25% in the initial coverage phase. And when you and your plan together for 2023 spend $4,400, you move out of an initial coverage phase and you move into the coverage gap phase of the benefit. And again, here, the maximum you're going to pay is 25% of the cost of the drug. Now, in this coverage gap phase, it's typical that you will pay that 25% of the cost of the drug, okay? And you'll notice that this is where this used to be that donut hole piece. And we've seen that the donut hole really has gone away. But when we talk about the donut hole going away, people misconstrue that to think that you're not going to have cost. You're still going to have costs throughout the phases of the Part D benefit. But now you're seeing that cost is no more than 25% in that coverage gap phase. So that at least that's something. The last part of the prescription drug benefit is when you have paid up to $77,400, okay? You, or it's a variety of people. It's largely you, or if you work with the SPAP plan, or you work with a charity, or people buy some drugs for you on your behalf, that you will then move into the catastrophic phase of the benefit. And that is when you would pay no more than 5% of the cost of the drug, all right? So that is, you can see that when you present yourself at the pharmacy, depending on where you are, your copay could be very different each time. So that's an overview of the Part D drug benefit. Let's move on to the next piece. And this is where we're really looking at the different types of drugs and Part B versus Part D drugs. And for the most part, Part B covered drugs are drugs you can't do at home. Normally, there are things that are happening in the outpatient departments, like infusion drugs, or you have to get something through your part of it is through a DME supplier, okay? Let's see, oral anti-cancer drugs, that they were once available only through an injectable form, and that was how they were covered by Medicare Part B. They're going to still remain Part B. So now they're oral, but at one time they were like an infusion type drug, or they were an injection. They're still covered under Medicare Part B. Your oral anti-nausea drugs, they're also covered by Part B, and then your flu shot, your pneumococcal vaccine, your hepatitis B, and your COVID-19 vaccines. So these are all Part B drugs. And remember, so you'd have a copay with them. But that's when you have that Medigap plan. That Medigap plan would be the one that would cover that 20% coinsurance. On your Part D side, this is going to be normally drugs you're getting from the pharmacy, or maybe your pharmacy supplier, not pharmacy, or your specialty drugstore. And these are typically things that, like an inhaler or a prescription drug. So you can see that that's normally what you're going to use at pick up at the pharmacy, or get from a pharmacy, or you get through a mail order. And those normally are going to have a copay. And that was all that Part D variety of cost sharing. And so that it gives you an idea of the different types of drugs covered for Part B and covered for Part D. All right. And just lastly, just know that there are Part D vaccines which are covered. And that would be like your shingles shot. And what else is I think it's the diphtheria shot and like the whooping cough shot. Those are all covered under Part D. All right. Let's move on to our next slide. And as we talked about before, plans change every year. What they cover change every year. And you're going to want to make sure you shop for that every year. Okay. And as I said, read your annual notice of change, your explanation of benefits. And there is a tool out there, which is the Medicare Plan Finder, which can help you compare plans. And, there are a variety of questions you want to ask yourself as you're doing the plan comparison. If you're looking for a drug plan, you'll want to make sure, are the drugs on the formulary? Are there any types of restrictions on those drugs, such as, is there a prior authorization requirement? Do I have a step therapy, which means I have to use a cheaper drug first? Are there quantity limits that are hard for me? Are there pharmacies nearby? And is the mail order less costly? These are the kinds of things. If you're looking about changing your Medicare Advantage plan, you want to make sure that your providers that you use are in the network. You have to be comfortable with, and again, all those prior authorization requirements. Are you going to be eligible for extra benefits? There are extra benefits, but they're not available to everyone who enrolls. You're going to have to see, do you have a diagnosis that allows you to get some of these extra benefits? And you'll certainly want to check the drug coverage on those. So go ahead, let's move on. And I think this is if you want to go into the Medicare Plan Finder, this will step you through the Medicare Plan Finder process. Okay. And this is the tool that is available on the www.medicare.gov website. And what you want to do is, if you're going on the website, put in that address, and you'll want to check your plans. And there's a situation now where you can create a login for yourself for the Medicare.gov website. And that's where you can see that login button if you create one. But if you don't want to create a login, you don't have to. And that's just continue without logging in. So let's go ahead, and the next slide will give you an idea of what's going to happen. So the next step would be identify if you get any help covering any of these costs. Are you eligible for some kind of benefits? Do you get Medicaid? Do you have a program called Extra Help? And typically these are programs that are available to low-income beneficiaries, whether you're enrolled in the Medicare Savings Program or the low-income subsidy programs, or you can just say, I'm not sure if I get any of these, or I do not have any of these. But you'll want to make sure that you select, if you're getting on Medicaid, or you're enrolled in the Extra Help program, you want to make sure you click on those, because that will change the costs that appear on the Medicare Plan Finder. So let's go to the next slide. Okay. And then what will happen is you'll enter all your drugs, and you're going to select the pharmacies which you prefer. And then you're going to get a Medicare plan results page. Okay. And on that plan results page, and it gives you basically telling you, hey, this is the cost. This is the premium for a plan. And this is what it gives you, a calculation of all the costs you're going to have for the year. What I would recommend for you to do is please go into the detail page on all the plans that you come up, so you can get to find out what's covered. All right. So let's go to the next slide, and actually goes on the plan detail page. And you can see here, it gives you a list of the premium, and it gives you generally what's going to be covered. Also gives you the cost of the drugs over the course of the year. So that gives you a general idea of cost. Let's go to the next slide, because I want to show you something what I think is really important on that plan detail page, please find this link, okay? It's called View More Drug Coverage, because under that link is going to show you whether or not a drug is it covered under the plan? Is it on the formulary or not? Okay. And if it's on the formulary, it's going to tell you what tier it's on. It's going to also show you what kind of restrictions, if any. It'll show you if there's a prior authorization requirement, meaning you have to get approval. So to me, this is a really important screen. And unless you know, because you want to know if a drug is covered or not covered. All right. So make sure you click on View More Drug Coverage to find out if there's some type of limitation on your availability of this drug, or if there's a kind of limit on the quantity that you can get each month. So that gives you an idea of some of the things to look for as you're shopping for a plan. Let's go ahead to the next slide, because now we can take a little bit closer look, and maybe you're looking at a Medicare Advantage plan. Similarly, you'll put all it's the same type of search, and you can just switch over to the Medicare Advantage plan. And you're going to get a list of plans that operate in your area. And again, you're going to want to go onto that plan detail page. So let's go to the next slide, Josh, if you would. And again, you want to look at the detail of each of these plans. And again, it's going to tell you, hey, on this plan, you don't maybe have to pay any extra premium or something, but gives you an estimate of the cost you have for the year. And you can see that there are extra benefits listed here. You can click on each of these different things, because you can find out, how do they cover drugs? What's the star rating? What are the extra benefits? You'll want to go in there and check for each of those pieces to find out if there's more information available to you on that Medicare Advantage plan. Again, don't always go by your premium cost, because it's a lot more than that. A lot more than premium costs are involved. And if you wanted to find out if your doctor is in this Medicare Advantage plan, what you actually have to do is you go into the detail page like this, and you're actually there's a place to go check for providers, and you have to go out from the Medicare Plan Finder and go to each plan's provider directory, which is not on the Medicare Plan Finder site. You're going to have to go on the individual plan directory for each plan to locate your doctor. So that is certainly one of the downsides of the Medicare Advantage or the Medicare Plan Finder. It doesn't list doctors that are on the plan. So let's go to the next slide, if we will. And again, this goes back into going into more detail on the Medicare Plan Finder, or on Medicare Plan Finder. This shows you the different types of extra benefits that are out there. So I would just say take a close look at that and see if it's anything that you're interested in. But you'll notice it doesn't give you a lot of information. It just says there may be some coverage, there may be no coverage. If you really want to know more about these extra benefits, you're actually going to have to go on the plan or call the plan too. So let's move forward. So if you're interested in joining a prescription drug plan, or you're interested in joining a Medicare Advantage plan, you have a number of ways to enroll. You can just call the plan. You can go onto the plan website and enroll. You can call 1-800-MEDICARE and they can facilitate your enrollment. Or you can actually do a paper application, and know that if you are enrolling into a new plan, you are automatically disenrolled from your previous plan. Right? And if you need help, because this is complicated, what I would recommend is contacting your local state health insurance assistance program. And the number here and the website is like the national number. And what you can do is you can go on call that number, and they can give you your local SHIP plan. There is a SHIP not only in every state. A lot of times most counties or regions have a SHIP. So if you know that you were looking to change plans, you should contact your local SHIP to see if you can get an appointment, or they can help you with this type of selection. They do help people make plan selections. So that's what I would do. And also you can certainly call 1-800-MEDICARE and they can help you as well. So that's how I would navigate getting with a plan choice. People also use brokers too. So I know that too. I work with the SHIP, so I always recommend them. That's why. So just to give you an idea of some Medicare cost for this coming year, this is just really a comparison from last year to this year. Your Part A deductible, has gone up. Interesting, your Part B deductible has gone down from $233 down to $226. as well as your monthly standard Part B premium this year is $164.90. And I want to point out that if you make over certain amounts, in this case for 2023, if you as a single person make over $97,000 a year, or a couple, you make over $194,000 a year, your Part B premium is going to be higher. It's called an IRMA. It's a Medicare. It's a Medicare adjusted rate. It's income related Medicare adjustments, IRMA, and that means you're going to pay higher than that $164.90 per month. Okay. And lastly, that Part D deductible is $505 up from $480. Okay. So let's move on to our next slide. And the last piece we're going to talk a little bit is about some changes into Medicare benefits for 2023 that you could look forward to or not. Just know, as you all know, we're still under this public health emergency. And under the public health emergency, there's a lot more telehealth available. And that will continue until 151 days after the public health emergency ends. So let's say the public health emergency ends, I don't know, I've heard March, I've heard July. We have 151 days past the date of the end of the public health emergency that any of the expanded benefits of telehealth will remain in place. All right. There is a new benefit if you have received a kidney transplant. There is now a new Part B benefit, which just covers immunosuppressant drugs. So if you got a kidney transplant, normally you are eligible to remain on Medicare for 3 years at post-kidney transplant, but then you will be taken off unless you're turned 65 or you are determined to be disabled. This new Part B benefit would allow you to pay a separate premium, and that would allow you to get access to those immunosuppressant drugs and not have to be on Medicare Part B. It would be a separate benefit. And lastly, there is Medicare, or CMS has recognized that there have been a lot of ads that are out there for those Medicare Advantage plans, and I'm sure you've seen them. And there is increased oversight for those Medicare plan marketing. What you're going to find now is they're going to be recording any calls that take place between beneficiaries and representatives of plans. And they're going to record all the calls to make sure things are not done inappropriately. So I'm sure we all have stories about seeing some of the plans and people finding themselves, they're enrolled in the plan and they didn't sanction that enrollment. So know that CMS has gotten a lot more complaints, and they're going to do a lot more to try to curb some of that activity. But I think that covers last thing. Just know the changes to prescription drugs. There is limit on prices increase. We know how fast prescription drug costs are rising. And what we're going to find is there's going to be a limited to, the limits on the amount that they can increase drug prices moving forward. There's also a cap on insulin costs, $35 a month if you take insulin. And something that might apply to this group is that there's going to be no charge for vaccine, for Part D vaccines, which are the shingles, the flu, and the Tdap. The flu shot, I don't think that's right. I think the flu is Part B. So I think that's incorrect. But there will be no cost sharing on those. But I'll confirm that for sure, because I don't think that's right. Okay, last thing. There's been a new act in place, the Inflation Reduction Act, and there have been changes to the prescription drug benefit. And some of the benefits we have already talked about is that there's that $35 copay only for insulin, eliminating the cost sharing for shingles. Oh, the flu is there again, so it is correct. My error. As we look forward, other changes we can look forward to in 2024, it's going to eliminate that 5% catastrophic copayment for Part D. It's going to, for the extra help, this Part D benefit, it's going to remove the partial coverage and make everybody have full LIS coverage. They're limiting the Part B premium increases to 6% a year. And then the one I want to just point out is really this happening in 2026 or 2025. It's going to cap the prescription drug out-of-pocket Part D benefit cost to $2,000 a year. To me, that was the one I really wanted to get to. So if we can get through 2023 and 2024, we actually may see some true max out-of-pocket spending to $2,000 per year in 2025. So on that cheerful note, I will stop.
All right. Thank you so much. We do have a bunch of questions that I'm going to bring up here in a second. First and foremost, I will say flu shots are covered under Part B. Just
thank you.
Looking at real quick, there's your from Medicare.gov, certainly covered under Part B. So that's all good and well. You know, we certainly, and you touched a little bit about it, but this was one of the questions, Medicare coverage for oral chemo versus injections. You did talk to the point that injections that are done at an infusion center are certainly covered under Part B, and ones that were once an injection and now an oral are still covered. But what about oral chemo that is taken at home?
I would think there's a couple of caveats on all of this. Normally, if it was an injection, like we said, I think there's a lot of caveats in that. That's a good question. I'm not going to have 100% answer. A lot of them are covered under Part B. I can't say all of them, but a lot of them are. And I believe one of the issues that sometimes it's covered for Part D, if it's not covered for the cancer itself, it's some side diagnosis, maybe a side effect. It's treating a side effect, and that's when it may be covered under Part D. It gets kind of weedy. From what I understand, a lot of the oral cancer drugs are covered under Part B, but it's hard to parse out what are treatments for the cancer versus what are treatments for the side effects. And so I believe those are the ones that end up being covered under Part D.
Right. So, you know, one of the questions certainly came up was on a drug called everolimus, which is an mTOR inhibitor and is something that's quite expensive under, you know, it does show up as you can get Part D coverage for it, but it certainly wouldn't be something. This is actually you know, looking at the particular drug itself, this is the challenge of this is for just everolimus. And you can see it's actually rather expensive to get as an oral drug. Although, fascinating enough, I always remind people that they should, and I'm not sure, this is also 12 months, and I'm not sure anyone is on it for a full 12-month cycle. But it always reminds me that even whatever you're doing, you should actually check things like GoodRx and other things. This is everolimus done as a using GoodRx for the normal one dose pack of 28 tablets, 10 milligrams. And you can see that actually, if you were going on 4 months of this, it would be far cheaper to just buy it directly without even using any insurance than actually going and using Part D coverage if that was what it was under. So I always recommend people, there's a few of them. Mark Cuban now has a new site as well that looks at drug costs. There's a few competitors to GoodRx as well, not just plugging them here. But it always is important to look at every drug that you are on, regardless of whether it's in your formulary as well, just to see if there is another way to make that work better. And so just a reminder that always good to check multiple sources for how to get your drugs.
Great.
Let's bring up another question that I have going on right now. Monthly lanreotide, there's certainly some questions about lanreotiders or somatostatin analogs. The other one is sandostatin as well. This is a complex question that has lanreotide, liver MRIs every 6 months, PET scans every 2 years. So the liver MRIs every 6 months, and PET scans every 1 to 2 years certainly seems well within the reason. Standard of care, which you could look under either NANETS, certainly has, or the NCCN, both have guidelines that would be used to see what standard of care is and make a good argument for what that would be. These fell well within that. And lanreotide being an injectable that is given at an infusion center, as you pointed out, is covered by Part B. And it's really important to have a Medigap. These are not inexpensive applications, costing 4 to 5 figures a shot. So having a Medigap coverage is hugely important here. There was another question as well on using something like a copay plan. Like one of them that was mentioned was Ipsen Cares. There's also Novartis certainly has plans for their sandostatin shot as well. So that's and we didn't talk about copay assistance plans under Medicare. Do you want to cover that for a second?
Well, basically, here's the issue with the copay assistance plans. Anything that's going to be covered that way, in Medicare, that's not going to meet any of your deductibles or out-of-pocket requirements. So it's almost like a balance. If you, so Medicare always says, if you're going to do that, just know that you're not going to get yourself through that donut hole. You're not going to get yourself through that initial coverage period. The donut hole, you're not going to reach. It's going to be harder to reach your catastrophic coverage. That's what they always say. Doesn't mean that they're not a good idea, and doesn't mean it's just knowing that in that sense they don't operate together.
Well, and honestly, for most indications, drug copay assistance plans will not work inside of Medicare,
right.
Because it's considered giving an incentive to a federal policy. However, there's a couple of things to think about that. To the person who's in Ipsen Care, there are other benefits to being in Ipsen Care, whether it is home nursing calls, other different things. These are free services that these companies do offer, which they can still offer that guidance to Medicare recipients. That doesn't cover copays, but it will cover some more psychosocial aspects of this. And so it's still a good idea to check in with that. The other things that they may lead you to, I'll put this up right there. This is the Lewis Merrill Foundation. This is one of a few foundations that will also give you copay assistance for drugs to help you meet that copay. These are foundations and not part of any drug company, so they can actually do this with Medicare recipients as well. So I will say one thing is apply early and cover your bets, because they run out. When they run out of money, they run out of money. So they approve for a certain period of time, and then they, once they've got the number of people that they'll be able to cover for the year, they'll turn away people. So when you're looking at those types of things, make sure that you're getting, that you do that quickly. So, one of the first questions is everolimus, which is an oral chemotherapy, covered under Plan B or Plan D. Do ask your cancer center as well how they bill that, because they will say what they will bill it to or how they will bill it. You may also use that SHIP program to talk about your individual situation as well, because that's hugely important to understand your individual situation. So, and as with anything here, we're certainly giving informational things for you to start on your journey, but really do check this out with a SHIP counselor, or send specific questions to Anne as well, whose email we'll put that back up here as well as we're talking, so that you can find that as well, and she'll at least point you to the right direction. So I'm looking through some of the questions here. let's see, we've got the oral one. Oh, so this is a question, and I'll put that at the bottom as well.
Mm-hmm.
So here is someone who is on Kaiser Advantage because Kaiser only offers Advantage for Medicare, and they are looking to switch to a plan at Blue Cross with a Medigap policy. How can they be sure that your planned surgery would be covered in follow-up care?
You know, I'm curious. Okay, so my first concern would be, are you in the Medigap policy? I mean, that would be the one thing. I mean, right now, so you're moving from a Kaiser plan. Can you get into this Medigap policy? That would be that would be the first thing.
When you apply, do they tell you right away that you're approved for the Medigap, or is there a waiting period or an underwriting period?
I'm sure I would say you're probably going to have to at least wait 30 days just to get a response to know.
I think that's the question, because you're clearly coming with a pre-existing condition. If you're more than a year into that, being on that Advantage program, I would be careful about making sure that you're approved for the Medigap before the Advantage runs out, because if for whatever reason they don't accept you in the Medigap policy, that would be challenging. If they do accept you, my assumption would be you should check with the benefits coordinator at UCSF to ensure that they would take that Blue Cross with the Medigap, although I'm reasonably confident that they would if you had it. But I think the question here, especially if someone has been on a Advantage program for more than a year, that they actually can get underwriting on the Medigap policy, which I think is a challenge.
Exactly.
So, we didn't get into the Plan Fs versus Plan Gs versus the different types of Medigap. Do you want to discuss those really quickly?
Sure. What it is for Medigap, what it is, they're standardized. So if you're whether you're buying a Medigap Plan A through Anthem or through, Fidelity or through, ABC plan, all Plan A's are the same. And your Plan A's are really kind of your slimmest benefit as far as that goes. And then there are plans, let's see, Plan B's and D's and N's and G's and N's. So know that it really almost doesn't matter what, if you want to buy a Plan G, then no matter who you purchase it from as far as a Medigap goes, it's going to be the same benefits. It'll have the same benefits. So keep that in mind. And normally, if you buy a Medigap plan, it's sometimes better to buy the richest plan first, because normally you can't. Well, if you buy, like, say, the Plan A, which is the least, the slimmest, it's harder to then up your coverage to a more rich plan like a Plan G. Whereas if you buy a Plan G, it's easier to slim down to a cheaper plan or to a less expensive plan. So keep that in mind. The richest plan is like the Plan G, and I believe it's the Plan D. Well, D is just for under 65. And I'm talking about Maryland because that's what we have here. But so what it is keep in mind that there is one plan, I believe it's the G's, that they cover. It's called excess charges. And excess charges is if your provider it'll cover basically anything that your provider will charge you. And some of the plans will only cover up to a 20% coinsurance. It's just the most thorough plan. So that's all I could say. And I know there was a whole question about which Plan Fs are no longer available to most people as they turn 65. If you were available prior to that.
Plan F is not available to anyone unless you're already on it, you're grandfathered. And that was because it had no copay at all. And I think there was a disincentive. They felt there was a disincentive. I think G is the
replacement plan.
That's the closest replacement. important to know also, you know, if you're in the retirement and still in really great health, or, you know, over 65, that one of the things that differ between some of the slim plans and the not so slim plans is international coverage. Being able to have coverage when you travel, which is really great to have. So do take a look and make sure that these things match your lifestyle as well to what you're looking at. I noticed that there were like 3 different versions of Plan G, which confused me. You know, there was the basic, the optimal, and the something else, and one of them had. It was interesting. There were some other things. Looking to see if we have any other questions that we can cover off. Hopefully, we've gotten to most of them. I'll put back your contact information as well. Most people on this will know how to get a hold of me, and I can also get to you as well. Any last words that you want to add to everyone?
I would say know what your coverage is. Please know what you do have, and I'm sure people on the call are using their coverage, so they're familiar with it. So I would always say that, and look at your annual notice of change that comes in the mail. Look at the evidence of coverage that you get, because it will talk about what is covered and what's not covered. I would also say, don't be afraid to talk to your doctor about if you're struggling with cost and how they can help too. Because remember, this is your partner in care, and they're there to help you. And it doesn't make a whole lot of sense to prescribe something that ends up costing you so much that you can't afford to do anything else, where it just takes away so much of your other livelihood. So keep that in mind as well. So,
and I'll make another plug for what you already made a plug for, which was checking and using your plan finder. The only reason I say that is, I think I've read some statistics where, what is it, less than a third of us, or between a half and a third of us don't actually, or only a third of us actually use the plan finder to go look at costs. And these costs change yearly, and it's really important not to just look at the advertisements that are on air and say, okay, they say they're the best and it's good, but actually to use your actual drugs that you take and put them in the plan finder to figure it out.
The numbers are even less than that. I think it's closer like to 10 to 15% of people actually change plans on a given year. So if be one of those,
plans, it's more check plans,
check
right?
Plans.
You can't check your plan you can't change your plan until you check your plan.
Right. It's very small.
Just bringing up, it really is as easy as, I'm doing this in real time, so you can see what you're doing and taking a look at it. And I'm using my zip code here, but this is as fast as it goes. It's not.
Right. No, it's not difficult.
This is actually a government website that works incredibly quick, and you can put in as many drugs as you want, and you can see if they're here. So this is where you do that, and they take both the brand names or the generic names, so that you can find out what you're looking for. And I don't know the frequencies of everything, so I'm not going to embarrass myself by trying to do all of this. But
use the default. Just use the default.
Yeah, you can find, although the default for everolimus is not the standard default for. So
Gotcha.
Really talk to your provider, understand what it is that you will be taking. This is a great time to have that conversation, so that in fact you can actually make these changes and update your plan.
And if you have trouble, call your SHIP counselor. Seriously, they're a resource that you need to be familiar with, because also they can help you. If you have a denied claim or anything like that, they can also be of assistance there too. So it is and it's free, and it's an unbiased source of information. They are not in any way paid by any plans, or they don't benefit from any, however you choose to go. And they are really a wonderful, wonderful resource. So I would highly recommend that you utilize them. And they're in your community, so they're going to know the plans and things that you're familiar with. They're the ones that you have options on, so they'll know a little bit more about them than anybody
here
else.
Is just how fast you can get into the appropriate CHIP area that you're looking for. So this is the California CHIP plan.
Yeah, they have a wonderful program, the HiCap program. Yes, they do.
So with that, thank you again for doing that. And I just want to let you know, NorCal CarciNET has donated on your behalf to the National Council on Aging.
Oh, thank
you so much for all the work you do for us. And we look forward to continuing the relationship.
Well, thank you so very much for that generous donation. And thank you so much. It's been a pleasure, as always, to be here. I always learn something, and I'm really happy to be of assistance to this wonderful population. Okay.
So with that, I'm going to end the broadcast. You and I can stay on for a second.
Mm-hmm.